Welcome back. On behalf of the MDRN Collaborative, my name is Irina Yudin, and in Module 3 we will talk about arterial lines. An A-line is a thin catheter placed in a patient's artery for the purpose of real-time blood pressures and to obtain arterial blast gas measurement. An A-line should never be used for injectable medications, as the drugs will be delivered straight to the tissue bed, potentially leading to serious tissue damage or necrosis. All A-lines should be carefully labeled to avoid this. There are several indications for arterial lines, as you can see here from the list. Let's just go over this list. Hemodynamic instability, hypo or hypertension, vasoactive medications, hemorrhage, shock, cardiac arrest, during invasive procedures, and surgery. The other way of looking at this is anytime you need to provide close or continuous blood pressure monitoring, as in cases of hemodynamic instability for whatever clinical reasons, and or frequent phlebotomy or IBG's measurements, your patient will benefit from arterial line placement. Let's go over some important do's and don'ts for A-lines. Do: utilize the VAMP system for closed needleless blood sampling. This reduces infection and blood loss associated with frequent phlebotomy. Make sure your reservoir bag is changed every 24 hours and the counter pressure on the bag maintained at 300 millimeters mercury. Always have your alarms on. I'm going to take an extra minute here to help everyone understand the importance of this point. A-lines are configured in our telemetry system with a 3-star alarm. A 3-star alarm represents an emergency. So when you turn this off, you place your patients at serious risk. The 3-star alarm goes off when the pressure against this invasive line is no longer detected. This happens when it gets disconnected or you turn your stopcock to the off position. If these scenarios are not corrected immediately, you could lose the line, not be aware of hemodynamic changes. In the worst case scenario, not be aware that your patient is hemorrhaging from a disconnected line. There is never a circumstance when you are allowed to shut this alarm off. If the tracing are dampened or pressures are inaccurate, but you still need the line for phlebotomy, adjust your alarm settings, but don't shut off the alarm. Be sure to get an MD order if you need to change your default alarm parameters. This goes for the above scenario, but in other cases like managing acute hypertensive crisis, the clinical parameters on these patients don't generally fall within the same range as our system defaults. Remember to maintain the transducer in a level position to ensure accurate displays of information and data capture in a CS link. This is a bit of a maintenance project, as other providers, patients, and families can change the bed position. Now, let's do the don'ts. Don't keep your patient's wrist hyperextended on the arm board. These are for the insertion only and can cause neuromuscular damage. Don't leave white caps on pressure tubing. Change to the yellow caps during setup. This can represent both an infection risk and a bleeding risk. Don't let your pressure bag run dry. If you're changing this every 24 hours, it is unlikely that it will run dry. When the bag is maintained at 300 millimeters of mercury, it will infuse 3 milliliters of volume an hour to maintain line patency. On the next few slides, we will go over the pre-procedure, intra-procedure, and post-procedure care and monitoring for A-lines. So for the pre-procedure care, you will want to gather equipment, including your procedure card, portable ultrasound, anesthetics. These lines hurt. Don't let your proceduralist proceed without giving the patients the benefit of the lidocaine, and your tubing setup. You will need pressure tubing setup, C-clamp, leveler, cable, 500 ml bag of saline, and a pressure bag. If you don't anticipate additional invasive line monitoring, such as CVP, just grab the single line setup. Get this up and operational before the procedure begins. Pre-procedure safety considerations, patient preparations, and patient teachings include: consider the patient's past medical history. Conditions such as diabetes, high blood pressure, peripheral vascular disease, any vascular grafts, vasospasms, and embolisms can place your patient at increased risks for infection or further injury. Evaluate for any coagulopathies by the way of current meds or underlying medical history such as liver disease or thrombocytopenia. Transfuse before or during procedure as needed to minimize bleeding risks. Consider patient's allergies. Make sure the proceduralist evaluates collateral circulations through the modified Allen's test. You're familiar with this from ABG certification. Perform patient teaching and offer support to both patients and family as needed. Make sure the consent is obtained and be present to initiate timeout before the procedure gets underway. Intraprocedural care and monitoring for an A-line includes washing your hands, wearing gloves, and maintaining sterile procedure with all assists. Ensure that your monitoring equipment is set up and functional. Once the line is in place, hook it up and confirm the positioning by displaying an appropriate waveform. Perform the square test to evaluate the quality of waveform and accuracy of reading. Double check to make sure your alarms are on and parameters are appropriate for your patient. Secure a sterile Primapor framed occlusive dressing. Immediate post-procedural care and monitoring includes making sure that the line is functional and you can withdraw blood from the catheter. Assess that peripheral vascular and neurovascular systems are intact. Utilize the line to identify and treat alterations in hemodynamics. The ongoing monitoring of the line include observing site for signs of hemostasis. In other words, make sure they are not oozing or bleeding from the site. Report to MD your findings. Treat any coagulopathies if necessary. Observe insertion site for post-procedure complications as just suggested. Check for change in color, size, temperature, sensation, and movement. Observe for signs and symptoms of infection. Complications that result from arterial line placement include hemorrhage, neurovascular compromise, hematoma, pain, vasospasm, infection, and catheter occlusion. When you sit back and look at this list, you can see that when following the appropriate pre, intra, and post-procedure care recommendations, you can play an important role in prevention. Well, that concludes Module 3 for arterial lines. Thanks again for your attention.